Hello and welcome everybody. Sorry for that. We had a bit of a technical difficulty there for the first minute or so. So I can see you're all joining now. There's lots of you coming online. Perhaps you couldn't enter because of that difficulty. So just let me know, can you all hear me okay? And can you see the screen? If you can you just put your hand up on the panel on the right-hand side? Oh, thanks, Nicolene. Great. Well, Nicolene can hear me, but none of, and Ash, great. All right, and you can see the screen fine as well. Narelle, thank you. Great. Salma, Samantha, fabulous. All right, good. Sounds like you can all hear, which is fantastic. So tonight what we're going to do is talk about what MTHFR is. And for those of you that haven't listened to one of my webinars before, I'm just going to give you a little bit of a background. But I'm sure that most of you are online because either you don't have a practitioner and you've tried to use some of the methylated supplements before and perhaps you're not or you haven't had the best success. So we're going to answer as many questions as we possibly can in the time that we've got. And there is a question bar on the right-hand side, so any questions that you do want to ask along the way, you can put them into that question box on the end. We do have an offer for you tonight, and Emma will be sending that to you, to your email addresses tonight, and also she'll put it into the handout section so you can see what those are. So, all right, let's get started because we've got a lot to get through. And if I could get that right. Okay, so we're going to talk about what methylation is and really how MTHFR actually does affect methylation. And also where it happens, because that's important too, that we know in what parts of the body we might be affected by methylation. And a lot of you have listened to my Facebook groups and my webinars in the past, so you might be au fait with this, but we're also going to run through where to start with supplementing. Now, I'm the first one to say it is best always that you make sure you are working with a practitioner. But I'm not silly enough to think that you're all going to do that. So the reason I wanted to do this webinar is that to give you some tips and guidelines that if you're not prepared to work with a practitioner, I don't want you to fall into the trap of taking lots of methylfolate, at least initially, and getting serious side effects. So I'm going to run through what those side effects are and how you can alleviate those, which I think is really important. We're going to talk about which B12 is the best one for you, what folate to choose and when, and if there is a side effect, what do you actually need to do about it? So when we look, and it's really important that we understand that when we are talking about a genetic mutation, we've got so many other things that we need to consider in the mix. And yes, the genes you're born with, you cannot do anything about. But what's really interesting is epigenetically, our genes can actually have mutations as well. And these are predominantly affected by our environment. So you can see here, processed foods and nutrient deficiencies or excess, pathogens definitely, so yeast, mold, bacteria, toxins that might come in from the environment, radiation, aging, drugs, sugar and carbohydrates, inflammation, and very much so in prenatal care. So all of these things can actually affect some of our genes and give us mutations that we may not otherwise have. And the good thing is a lot of these are reversible. So we're not talking about the DNA you're born with, we're talking about epigenetic changes, which are changes to genes that can happen after you're born. And it's environmental that this predominantly happens. Now, methylation. So what is it? Well, it's basically the ability of this methyl group that you see on the right-hand side, a carbon surrounded by 3 hydrogens, It's its ability to latch on to amino acids, proteins, enzymes, to activate and actually get them to work. Now, methyl groups also switch off a lot of things. So, for example, cancer-promoting genes are switched off by methylation, and that's a very important function. That's why a lack of folate has been attributed to cancer, for example, bowel cancer and other sorts of cancers, because we need these cancer-promoting genes turned off. But there are a lot of enzymes in the body that are methyltransferases and can only work if this methyl group is attached to it. Now, when we have a look at specifically some of the things that methylation does, so this ability of this methyl to work can turn our genes on and off. It repairs and builds our DNA and our RNA, and that's why it's so crucially important when we're talking about preconception and pregnancy. And that's why a lot of women who have miscarriages, it is attributed to a lack of folate. Also, as we age, we want these special things on the end of our chromosomes called telomeres to be tightly bound. That stops us from aging too quickly. And these are really important to the functioning of our genes. And if we don't have methyls, they can become unbound, and we don't want that. We also need methylation for detoxification of chemicals and heavy metals, because essentially this whole process supports and produces glutathione, which is our major antioxidant. So I'll show you these processes as we're going. Hormones. So our COMT gene, catechol O methyltransferase, is a methyltransferase that helps us break down specifically toxic estrogens. And so if we haven't got the ability to do that, we might end up with estrogen dominant conditions. So it might be fibrocystic breasts or fibrocystic ovaries or endometriosis, fibroids. For men, it may be prostate cancer. For women, it may be breast cancer. So we need to keep these hormones under control. It also helps build our immune cells, because we need these methyls for immune function, for protein synthesis. And you'll often see people with a low white cell count have MTHFR mutations. So they don't have these immune fighting white cells to fight bacteria and disease. One of the most important things is it really modulates our stress response. And I know a lot of people think this is very controversial, but I actually don't think adrenal fatigue per se is a real phenomena, because I really think when you get the methyl dosage right and you balance that methylation, all of a sudden people say, what stress? I don't really feel stressed anymore. Yes, there is stress around me, but gee, I'm coping with it a heck of a lot better than I ever did before. So we need, and that's why a lot of the times people can get into this hyper stress state because they've turned the stress response on, but they don't have enough methyls to turn it off. It provides us with our energy. So this methylation cycle you will see feeds directly into our Krebs cycle or our citric acid cycle, which supplies our energy. Our ATP, our CoQ10, our carnitine, we need methyls to do that. Reduces histamine. So a lot of people with allergies and eczema and hives and asthma, and particularly I see small kids with this, they don't have enough methyls to break histamine down. And so they're in this hyperallergic state because they haven't got enough methyls. We also need methyls to repair our cell membranes and produce the myelination of nerves, specifically because it gives us phosphatidylcholine. And phospholipids generally, there are three main phospholipids, phosphatidylcholine, phosphatidylethanolamine, and phosphatidylserine. And these make up our cellular membranes and basically provides fuel for our brain. So for those of you that can't remember where they parked their car or left their car keys, or they're looking at someone they've known for 30 years and they can't remember their name, it's usually not because they're getting Alzheimer's, it's because they don't have enough methyls to create phosphatidylcholine. We also need methyls to support neurotransmitters because SAMe, which is our universal methyl donor in the whole body, gives methyls so we can create dopamine, serotonin, norepinephrine, adrenaline, all of these things that we need, GABA, we need methyls for. So it really is a crucial component of our biochemistry. Now, things that affect it negatively, as I said in the very beginning, our environment is really key. And our environment ensures how toxic, I guess, we become and how much of a load we actually have on the system. So certainly environmental toxins are huge because bisphenol A pretty well inhibits methionine synthase. And that is the enzyme that allows us to utilize our methyls. And we get that from not only these endocrine disrupting hormones, but xenoestrogens from plastics in our environment. And a lot of the stuff that we put on our skin and use in our cleaning products are considered to be environmental toxins. Chemicals and heavy metals. Well, we know that people with MTHFR genes have a reduced capacity to make glutathione, and so they are therefore more susceptible to these chemicals and heavy metals. So the burden is already there, and that makes any lead or mercury even more of a burden. Stress, we've already talked about how important methyls are, and also on the flip side of that, the more stressed we are, the more we eat through our methyls. So just being stressed can really affect the whole methylation cycle. And a lot of the time people say to me, look, I've clearly had this gene since I was born, but how come just now it's a problem? And I usually say, well, have you had significant stress over the last few years? And invariably they'll say, yes, you know, my mother died or my father died or I had 3 miscarriages, or I've been really stressed at work, or I've been doing triathlons. So physical stress as well can deplete these important methyls. And obviously as we age, that's another key component because, you know, really things don't work as well. We can't produce as much as we used to be able to produce. Aging. We said, you know, decreases everything. Medications, so people on proton pump inhibitors or antacids are particularly at risk because it depletes hydrochloric acid, which affects our ability to absorb B12, and without B12, we can't use our methyls. So they're sitting there, but we can't use them. So vegans and vegetarians are particularly at risk. Diet. Obviously, the better our diet, the more leafy greens we've got in that diet, the better we are able to produce more folate, because 50% of a 50-cent piece is much, much less than 50% of a whole big bowl of lettuce or leafy greens. So the better our diet, the less processed food we've got in it, the less environmental impact we have on our genes. And alcohol too, particularly alcohol in excess, because it just depletes all our nutrients, but specifically our Bs. And when we look at methylation and some of the conditions that are associated with a lack of methyls in research, it's a pretty big list. And this is by no means exhaustive. There are a lot of other conditions too that we can now put onto this list. So you can see ADD, ADHD, addictive behaviours, autism, bipolar, you know, all of these neurological conditions, depression, anxiety, they're all big issues because we just don't have enough methyls, and that methyl may be affecting our serotonin in one person or our dopamine in another, or we may have an imbalance in serotonin and dopamine. We might have the COMT gene that does affect dopamine, that's raising levels too high and reducing our serotonin levels. So, and even people who go on a ketogenic diet, they are definitely increasing dopamine levels, but for everybody, that's probably not the right answer because you haven't got that balance between the dopamine and the serotonin. So, as we said before, our methyls are crucially important, and this ability to switch the activities of cells on and off and actually heal cells is the most crucial thing. Now, when we talk about a mutation, there are a lot of things that can happen if a gene is mutated. Now, you can see there on the left we have guanine, adenine, thymine, and cytosine, and they're our DNA bases. And it's like a jigsaw in a way, that you put them in slots of 3, and they make up many, many different combinations, and those combinations give us a protein function or an amino acid function. Now, sometimes when you have a mutation, it actually doesn't do anything. There's no effect to the gene at all. Sometimes it just works partially. Sometimes it actually completely changes how the gene works, and sometimes we don't get any real protein out of it. So in the case of MTHFR, however, it is a down regulation. So it affects the enzyme, the MTHFR enzyme, to basically not work as efficiently. Now, there are about 30 different MTHFR genes, but we really only focus on 2 of them, primarily only because that's where the research is at this particular point in time. And there are new variants that we're starting to see some of the research now. But for those of you that have the 677T, it really means that the cytosine has been changed to the thymine at position 677 on chromosome 1. That's basically what it means. Sometimes you see it written like this, and every single gene has what we call an RSID that identifies it exclusively, because then when you're searching the research, you can look. And basically, sometimes some of you will have seen your results written like this, which means that this DNA base change has affected the amino acids. So this is written as the amino acid change. So it gets confusing, and that's why searching for the RSID is often the best way to go. But basically, these all mean MTHFR C677T. In the case of the A1298C, same thing. The adenine is changed to a cytosine at position 1298. And basically, this is your amino acid change. And your RSID is exactly the same, except instead of a 3, you have a 1 on the end. Now, basically think of your mum and your dad both have 2 sets of every gene that you ended up with. So in the case of the 677T, mum had 2 and dad had 2. Now, it's absolutely random and it's potluck which one of those you are going to end up with. And you may never know, but let's say mum has homozygous 677T and dad has no mutation. You will only ever end up with a heterozygous SNP. But if both of your mum and dad have 2 copies, let's say they each have 1 copy of the gene that's mutated and 1 copy that's not, then you will end up with, the chances of variation of 50-50% of having a homozygous. Actually, you'll only end up with 25% of a homozygous if one of them has homozygous, you'll end up with a 50% chance. So basically heterozygous means you got a mutated copy of that particular gene from your mum or your dad. If you're homozygous, it actually means you got it from mum and dad. So you ended up with 2 copies. Now we look at those 1 or 2 copies and we say, well, we know from the research that there is a loss of function of that enzyme. So it doesn't produce as much folate as we want it to. So in the case of the 677T heterozygous, it is roughly a 30 to 40% loss of function. If you're homozygous, it's much higher. So it's 60 to 70% of that methylfolate is not going through the system. Heterozygous A1298C, we know it's a loss of function. It's probably not that significant, and just increasing, leafy greens would probably be enough. And if you're homozygous for the A1298C, roughly a 40% loss of function. And if you've got 1 of each, so if you're heterozygous for this one and heterozygous for this one, we call that compound heterozygous, and that's a 40 to 50% loss of function. So that's quite considerable, given that only 30% in some cases of 677T homozygous folate is getting through the system. So let's have a look at what that looks like. So when you are eating folate, your folate comes in as dihydrofolate. It gets converted to tetrahydrofolate, and all the way down here, and with the help of your MTHFR gene, you create 5-methyl tetrahydrofolate, which is our active. Now, if you are having folic acid, so folic acid is our man-made supplemental folate. If you are having that because you're eating lots of bread, because by law, all bread flour has to be fortified with folic acid. Now this folic acid, we know this DHFR, dihydrofolate reductase enzyme here, can only cope with 200 to 300 micrograms per day. So if you are having, let's say you're having some bread and you're having some cereal that's also fortified with folic acid, and then you take a supplement on top with folic acid, all of a sudden you are putting pressure on this enzyme. What happens? It slows down. And there's some research to suggest that it gets inhibited totally. So what does that mean? It means we're not getting folate through the system at all. Yes, if you're eating dietary folate, you might be able to bypass it and get this faster DHFR enzyme working. But if this is inhibited by folic acid, you actually have a big problem with your folate. And this folate goes on with the help of B12 to create methionine and SAMe. And this is our pharmacist. So I think of it like this. This is your production company. He's making the product. Your B12 is your courier who is moving the product. And Sam, think of as your pharmacist who is distributing the product. And you may have a problem in any or all of these systems. You may not be producing enough. You may not have the ability to move it even if you are producing enough. And your pharmacist might be sitting there with no product saying, hang on guys, what's going on here? So that's one of the reasons we say go gluten-free, because we don't want you having commercial bread flour fortified with folic acid. And there are little boutique bakeries that do not use commercial flour, and they're certainly a much better option. Now this is really a bigger picture of what we just saw. So here's your folate pathway again. Here's your B12 that sits in here and gets recircled, picks up this methyl, moves it to methionine, and here's SAM. So methionine will get converted to SAM. It gives off all the methyls to everybody that needs it. and it comes down here unmethylated to form homocysteine. Homocysteine picks up the methyl again, and so continues the process. And down here is where we, with the help of B6, we are creating glutathione, which is our major antioxidant. Now remember I said our energy cycle is downstream. Well, our energy cycle is here. So if we have problems with any of these pathways, you can really understand why a lot of our patients present with chronic fatigue, and they just don't have the energy to do what they need to do because it relies on all this coming down and supporting it. And here's our neurotransmitters. This is our serotonin, and here's our dopamine. And again, it relies on dihydrofolate reductase. So if it's being inhibited by folic acid, then our ability to create tyrosine, which then creates dopamine, and tryptophan to create serotonin becomes affected. Okay, so I don't know how many of you actually know that you have the MTHFR gene, and perhaps you could just pop that into the question box so I can see how many of you do. But I wonder how many of you you've been told, oh, you have MTHFR, here's folate, methylfolate, you take it. And I wonder how many of you had a reaction negatively to methylfolate. So Nicolene's saying she does, and Samantha does, and Lisa, her daughter, has, and who else? Leanne, yes, and Samantha, yes, Julie, yes. So you all do. Right, so yes, I'm not sure yet. So Narelle's not sure yet. Okay, so 5-year-old has MTHFR, that's Samantha, and Ash is saying headache. Not quite sure what that means, but Lee, yes, Lee does too. So most of you do know. And probably, oh, Ash is saying he got a headache when he took it. Got it. Okay. So some of the side effects for methylfolate are really quite serious. So increased agitation and anxiety, suicidal tendency. So it's actually not uncommon for our clinic to get a call from somebody to say they're suicidal because someone told them to take 5 milligrams or 2 milligrams of methylfolate. Increased fatigue, muscle aches, rashes, headaches, migraines. The list is quite extensive. And the reason you probably know now is that if you don't have enough B12 or some of these other pathways are blocked, your methyls will build up and you won't use them. And that's when you get the side effects. So where do we start? What do we actually do? Well, your family history actually gives you a big clue. And if you have a family history whereby there's been a lot of miscarriages by the females in your family, that's a big sign that perhaps the MTHFR gene is there. If you have children that have been born with cleft lip or cleft palate or spina bifida or any of these midline disorders, a hole in the heart, then that's also another big clue that the MTHFR gene is a problem. Those of you with cardiovascular disease who have had people in the family with stroke and heart attack, absolutely, it can be very much related to MTHFR gene because it will affect homocysteine. And when homocysteine rises, you are at increased risk for cardiovascular disease. So we need to ask the questions about what is your family history like. Your destiny will be more than likely that way unless you change the workings of these genes. So we evaluate. What's the first thing we need to do? Well, we have to make sure that before you put any methylfolate in there, we have cofactors in place, which means all those enzymes that work that you just saw, they have cofactors, nutritional cofactors, and many of them are B vitamins. And I'll go back and show you. So B6, NADP, which is crucial for your folate pathway, derives from B3, B6, zinc, SAM, which is your methyl, B2, B3, B2. So all of these have Bs that need the pathways to work. And even in the case of B2, it's your cofactor for the MTHFR gene. So by taking B vitamins without B12 and without folate first, stabilizes things. It gets things working before you start putting other things in. We also want to assess for B12. So any of you that are vegan or vegetarian, absolutely you do not want to be taking methylfolate until you have got B12 in place. Any of you that have gut issues, chances are your B12 is going to be low. If any of you have had to have a B12 shot in the past, chances are your B12 is low. So you have to get the cofactors and have to get B12 in place before you go anywhere. And that's the biggest mistake everybody makes. We then have to evaluate what's the best form of folate for you, because there's more than one, and I'm going to talk about that. And we also have to be very prepared for side effects, and we have to instantly act on them. Now, when some of you say to me, well, what's a clue perhaps that folate or B12 is low? Well, when you have a look at your red cell folate, if it's elevated and you're not taking supplements, then chances are you're not absorbing it and probably folic acid is too high. Serum B12, if it's lower than 358, it's low. I prefer now B12 to be 500 plus. So if you're looking at that, and we also have an active B12 known as holotranscobalamin, or you'll see it written on your bloods as active B12, it needs to be over 100. So if you're seeing your B12, and our reference ranges in Australia are shocking, it will say 158 is okay. It is absolutely not. And I would say if your B12 isn't greater than, say, 400 or 450, it's too low. If you have white cell counts, as I said before, or low neutrophils or low lymphocytes in your blood tests, you need to be thinking about B12 and folate. If your mean corpuscular volume, one of your red cell markers, you'll see this on your bloods, MCV, if it's greater than 90, it's probably B12 and folate deficiency. And or your red cell distribution width, another red cell marker. If it's greater than 13%, chances are it's B12 and folate, and so on. Elevated homocysteine. We are looking ideally for levels between, say, 7 and 8. Any lower, that's not good, and any higher, that's not good. We want to keep it in this good reference range. The Medical Journal of Australia in 2012 said that homocysteine levels greater than 9 micromoles per litre suggest the beginning of vitamin B12 depletion. And yet, our reference range with any of our blood companies says 15. Anything over 15 is higher, is too high. Well, this is crazy. So we need to be making sure that our homocysteine is sitting between 7 and 8. Increased creatine kinase, you're not going to see that unless a doctor has specifically asked for that, and low hemoglobin. Also GGT. Now, the reason GGT, it's one of our liver enzymes. If this is too high, so above 30, then that's a really good indication that our phosphatidylcholine is low. And remember we said that we need methyls for phosphatidylcholine. Same with all our fat-soluble nutrients and our cholesterol. We need to absorb this fat efficiently, and we need methyls to do it. So for those of you that are overweight and have said, well, I've tried every diet and I absolutely can't lose weight, chances are your methyls are low. Low blood pressure could mean that you have an elevated nitric oxide, and a high blood pressure may mean that you have low. And we look at the CBS pathway and some of the other pathways. It's not necessarily B12 and folate, but it definitely can be associated with a methylation issue. And thyroid function, I see it all the time, especially T4 being too low. And T4 is particularly important because your T4 makes B2, which is your cofactor for your MTHFR gene. So if you have thyroid dysfunction, chances are you're going to have low B2, which is going to affect the stability of your MTHFR gene. And how many people have thyroid function issues? And the problem is we only really test TSH. TSH is thyroid stimulating hormone. If you look on your bloods, you really need that to sit between 0.5 and 2. If it's outside that reference range, I would say that you have early signs of thyroid dysfunction and you need to get onto that. So let's talk about the cofactors that you need. So remember, we saw this, we said that there are a lot of cofactors in here that help all these genes work better. Particularly CBS, this is all B6 dependent. Our ability to create, some of you will have heard of folinic acid. Folinic acid sits over here. It's one of our active folates. It relies on B6 and magnesium. Our neurotransmitters all rely B6, B5, B2, and so the list goes on. And so the ones that we're particularly looking for are B1, which is thiamine, and it helps with acetylcholine synthesis, right? So important for our nerve cells, our hydrochloric acid, and it's also a cofactor for all these alcohol dehydrogenase genes, which are really important for breaking alcohol down. B2, this is our cofactor for our MTHFR. Really important also for our energy cycle. It is important for our glutathione reductase, and that's an enzyme that creates glutathione. So B2, so important, and if you have thyroid issues, that's probably going to be a problem. B3, we really need that for our energy, specifically our what we call our electron transport chain. B5, really important for serotonin and melatonin. So for those of you that can't sleep, we probably need to make sure you increase your B5. And B6 and biotin. And B6, as we said, our CBS pathway, our folinic acid relies on this. And our biotin, which is known as B7, really important for fatty acids and a lot of these reactions that help with our energy cycle. And so this is why I created Starter B. Starter B is basically B1, 2, 3, 5, and 6. It doesn't have B12 and it does not have folate, so that you can start supporting the methylation cycle without any side effects. And then once you know that you're fine with these and things are in place for a few weeks, you can then test your methylfolate. So as you can see, it's got B5, B3, B1, 2, 6, and biotin. And these are all very good therapeutic doses, because a lot of the multivitamins that you find are actually way too low to be therapeutic for a methylation issue. So at the same time, we can actually assess our B12. Now, there are a few forms of B12 that I want to take you through. So similar to folic acid, you have cyanocobalamin. It's synthetic, it has low biological activity, and it's really not, it does contain a cyanide molecule. And so it really isn't the best one to use, right? We then have hydroxocobalamin. Now think of hydroxocobalamin as your precursor to your two active B12s. Your two actives are methylcobalamin, which really works on your mitochondria, which works on your neurological function, and it's ideal for people who have MTR, MTRR, FUT2, and TCN2 genes. If you don't know what your genes are, but you get tingling and numbness and your concentration is bad and you can't stay asleep, then methylcobalamin is probably the best way to go. And unlike methylfolate, most people don't react negatively to methylcobalamin. Some do, but on the whole, most people are very tolerant of methylcobalamin. Now, your second active B12 is this one, adenosylcobalamin. And think of adenosylcobalamin as your energy B12. So one works on your neurological function, one works on your energy. So for those of you that have real energy problems, that have chronic fatigue, then this in combination with methyl may be a good option. And particularly if you have MMAB or MUT mutations, for those of you that know it, this can be ideal. Now, so you might ask, well, why would I use hydroxycobalamin? Well, for those people that have really low blood pressure and they have, perhaps they're smokers, or they have problems with, methionine being really low, because nitric oxide basically causes vasodilation. So the more vasodilation you have, the lower the blood pressure is. So hydroxycobalamin will help mop up that nitric oxide to stop the blood pressure going too low. So I would say if you don't tolerate methyls at all, then hydroxycobalamin is actually a good option, because your body then decides which way does it want to go. Do I want more methyl or do I want more adenosyl? So for some of you that can't tolerate methyl, this is actually a very good option. And some of the, if you have, as I said, if you have gut inflammation, or you're on antacids, or you've had gastric surgery, like gastric bypass, probably more than not, you are going to have problems with B12. Now, as I said, any gastrointestinal disorders, so Crohn's disease, celiac disease, pancreatitis, infections, too much alcohol, exposure to nitrous oxide. So if you've ever been to the dentist and had nitrous oxide, well, that's going to be basically eliminating your B12 because it inhibits methionine synthetase. Mercury interferes with B12's ability to cross the blood-brain barrier. Genetic disorders, we'll talk about those a bit, but definitely people with who are vegans and vegetarians, absolutely, can be catastrophic for some people. And I see that when people are really, they've been vegetarians for a long period of time, I often say, well, when did you start to feel sick and not well? And they invariably say, after your probably 18 months to 2 years after I became a vegetarian. So if you are a vegetarian or a vegan, you have to take B12. There's no ifs, buts, and maybes. Don't think that you can get your B12 from vegetables. It's a physical impossibility. Now, those of you that are on some of these other, like metformin, Mylanta, any of these, again, your B12 is likely to be low. So as I said, who's at risk? Vegans and vegetarians. People over the age of 60. Why? Because their hydrochloric acid will naturally decrease, and that will affect their absorption of B12. Anyone who's had any form of gastric surgery, on drugs, nitrous oxide, eating disorders, gastrointestinal disorders, and babies born to who have been breastfed by women who are deficient in B12. And so some of the signs and symptoms of B12 deficiency you may not think of, but I mean the obvious is numbness, weakness, tingling, pins and needles. But we can get confusion and depression and psychosis. Why? Because you can't use your B12, your folate. You cannot use your active folate. If you've got high homocysteine and low methionine, chances are you've got low B12. Multiple sclerosis-like symptoms. So I have a patient of mine who came to see me who said, I have MS. And I looked at his genetics, I looked at his B12. His level of B12 were low, but I wouldn't have thought so bad, but I went off the genes and I went off his symptoms. And for 18 months, I've been giving him huge doses, I mean huge doses of B12. And I spoke to him last week and he said, my MS symptoms have 80 to 90% gone. And he said, I'm wondering now if I actually had MS or whether I had a B12 deficiency. But the problem is, if your B12 gets too low for too long, you can have irreversible neurological damage. Chronic fatigue, you saw in the pathway why that might be the case. Same with infertility, because you're not using your methylfolate. Mental changes, so apathy, sleeplessness, so the ability to fall asleep. B12 is absolutely crucial in your ability to stay asleep. Memory loss, again, I would put that with phosphatidylcholine, but there are a lot of symptoms that you can see here, even damage to the optic nerve, inflammation, so many things can be affected by a deficiency of B12. We can also have what we call TIAs, which are transient ischemic attacks. And how many elderly people have a lot of these problems, and yet the most fundamental basic thing like B12 is not being given as a matter of course. Okay, so this is what I was talking about with the reference ranges. You can see Australia, it basically says, and you'll actually see some of them that says 150, 153. So they're saying that's okay, anything above 250. Sometimes they'll say 150. You can see in the US, it's a different picogram per milliliter as opposed to a picomole, but it's similar to ours, 150 to 650. Whereas the Japanese changed their reference ranges 2 years ago to say the minimum is 500 to 1300. So for those of you that are taking supplements of B12, I don't worry that they are too high. And then the related genes. So for those of you that know, it's the transcobalamins really that are the greatest risk, because it's the ability to, particularly this TCN2 and TCN3, these are the problem ones because you just don't have the ability to move them along. And I put this in just to show you some of the genes. So the MMAA, or that affects our adenosylcobalamin. MMAB, adenosylcobalamin. The MMAC, adenosylcobalamin. MTRR, methylcobalamin. MTR, same. So you would use different forms of B12 for different mutations on average. All right, so here we have our hydroxy. So if there's dizziness or low blood pressure, perhaps that's an indication that there's a high nitric oxide or hydrogen sulfide. So you would maybe think about using that. For people that can't use methyl, this is obviously a really good option. Adenosine, particularly when there's mitochondrial issues and energy issues. Methylcobalamin, when we see that there's neurological brain function, numbness, tingling, can't stay asleep, all of those things, you would think methyl. Okay, so the methyls we have methyl B12, and it's a chewable. And the reason that it's a chewable is because it will go directly into the mucosa and bypass the gut function. We want to bypass the gut, particularly when there are gut issues. So it's absorbed a lot better, and the research says that a sublingual and a chewable are just as effective as an injection. So here we've got our methyl and we've got our hydroxy. Unfortunately, adenosine is not available for sale in Australia, but you can get it on our international site, which you go into the shop and you press international, and you can get that just for your own personal use. We can't sell it to you here. All right, so what do you do when you've chosen which B12 is best for you? So you start with just a quarter. So you break it into 4, really easy to break it. You start with a quarter, and you take, which is equivalent to 500 micrograms, and you do it for 3 or 4 days, and you see how you feel. Do I feel okay? Does this feel fine? Am I getting any headaches or side effects? If you're getting a headache from the methyl, for example, and it's not too bad, then just extend that trial of a quarter for a week, because sometimes it does take your body a little bit to adjust to getting these methyls. If you're okay, you increase it to a half. And you keep doing that every 3 or 4 days until you are taking 1. Now, some of you who have a lot of issues with B12 might need 2, but you can gauge what you do and don't need. Now, you take that in conjunction with your starter B, and you do that for at least 2 to 3 weeks, preferably a month, before you start thinking about folate, because you want to get these pathways supported. You want to be able to use your folate when you get it. All right, so let's talk about folate now. So we have key, you have three key forms. Like with our B12, we have our synthetic man-made, which is folic. We have folinic, and you saw that in the pathway. It is activated, but it isn't our 5-methyl tetrahydrofolate. This is crucial for the regeneration and the continual movement and creation of 5-methyl. So sometimes we might use a combination. And many people actually have mutations in the gene that breaks down folinic. So they can actually feel quite sick when they take folinic. And that's an indication that you need to support the breakdown of folinic and give yourself 5-methyl. So folic acid, as we said, we don't want to be using that form. Folinic is also known as calcium folinate and 5-formyl tetrahydrofolate. So you might actually see those on labels as well. And our active is 5-methyl tetrahydrofolate. And this is the one specifically that's affected by our MTHFR gene. So just to show you where those are, folic acid is way up here, our folinic is here, and our 5-methyl is here. And this is what I was saying. So this 5,10-methyl tetrahydrofolate is really crucial for us to be creating this through the breakdown of folinic, because it comes up here to tetrahydrofolate, gets regenerated to 5,10-methylene, that gets then converted to 5-methyl. And so this is a very dynamic pathway. We also have 5,10-methylene getting regenerated to dihydrofolate. So this is really moving. We've got lots of things happening here. We've got lots of circulation of nutrients. And so we do need these cofactors in place to make sure that this dynamic pathway continues to move. So this is what I suggest people always do. So you've had the starter B, you've had your B12, you've done it for about a month, then you test the water with your methylfolate. Now, the way you do that is you get a methylfolate tablet and you chop it into 4, the same way that you did your B12. And you do the same thing. So you try a quarter. You do that maybe for a week. See how you go. You then try a half for a week. You then try 3/4 for a week, and then 1 full tablet. When you are taking 1 full tablet, you then take total B, which is starter B exactly with 400 micrograms of methylfolate and 400 micrograms of methylcobalamin. So you're then combining the lot. Now you may well want to continue to take additional B12 in addition to your total B, but that's the general process of what you should do and how you should do it to start, because some of you are not going to tolerate any B12, any methylfolate. And so And so here's our 400, 400, and it's still got exactly the same as our starter B. And we will be very shortly having a combination of methyl and phelinic, which is great. And hopefully they'll be out soon. Now, the side effects of methyl, we said before: headache, migraine, rashes, irritability, increase in anxiety, joint pain, muscle pain, insomnia, depression, nausea, etc. Now, as a general rule of thumb, if you get a headache and you get a mild muscle aches and pains, that's really common, and probably about 80 to 90% of people who first start methyls, they will get those side effects. That's why we want you to start slowly and hold it for a week to see how you go. Now, if, however, and it's really hard for you, if you are feeling your mood is going downhill, for you to know that you are actually feeling down or feeling suicidal. So what I always say to people is just have a pen and pad beside your bed, and every night rate your anxiety and your mood. So I say to my patients, just put a little thing, 10, what's your anxiety out of 10? Obviously, if it's 10, that's high. And what's your mood out of 10? Obviously, 10 is good. So if all of a sudden you see over some weeks you are getting your mood going down, you've got to go, hang on, maybe this isn't the right thing for me. My mood is decreasing and I'm really not feeling good. And that's the main reason I would say to you, be very, very cautious with methyl, because this depression can come on either quite quickly or very insidiously. So why does it happen? Well, some of you have a COMT gene, and until you support that COMT gene and help clear the dopamine, you can get an increase in dopamine, which actually makes you depressed. And it can make you cranky, and it can also make you very, very aggressive. You may have oxidative stress. So think of it like if you're sitting in a stream knee deep and you let out the water up the stream, you're going to drown. And that's what I liken it to. If you've got CBS issues, which is either oxidative stress issues or perhaps lots of gut stuff with oxalates and not enough B6 and not enough zinc, then chances are you're going to have a problem. So you're best to stick on your starter B and your B12 until you have fixed those problems. There might be a lot of brain inflammation. You might have viruses and bacteria. So you might have a sulfur sensitivity, which means the more you stimulate folate, the more sulfur you're going to create. So you've got to undo that sulfur sensitivity first. You might have elevated ammonia because of issues with CBS or a lack of glutathione. So all these potentially will cause a side effect when you introduce methylfolate. So the question you've got to ask you, if you're all right on starter B and if you're all right on B12, what is it that's now affecting this reaction with methyl? Now, some of you may never be able to go above half a tablet or 200 micrograms of methylfolate, and that's okay. Some of you may need to really push it to 2 or 3 milligrams, or 2 or 3,000 micrograms, which is 2 milligrams, to get any benefit, but it's all individual. And so that's why it's really important that you take it slowly. Now, whenever you buy folate, you must buy niacin, because niacin is your antidote. So if you get a side effect, so who was it? It was headache. It was Ash who said they got a headache. Right, so if that headache is unbearable, what you would do is you would take your niacin. So you take, this is a 50 milligram supplement, and you take one every hour until you feel okay. You stop taking your methylfolate. So you go back to your starter B, you go back to your B12, you stop your methylfolate, and you take the niacin until you get back to normal. So for some people, that'll be a couple of hours. For somebody else who might be depressed, that might be two days. But you can up that dose and use 2 or 3 or 4 tablets if you need to undo it quickly in the case of depression. So always, always have your niacin on hand as your antidote. Regardless of whether you think you need it, one day you might just overdose on your methylfolate and you will need it in a hurry. Okay, so as we said, there are a lot of drugs that affect methylation, and even if you are on some of these drugs, you can have an effect with the methylation cycle. So it may have nothing to do with your gut, but it may well have something to do with some drugs that you are taking. So always consider that pharmaceutical drugs, although they may be helping, may also be affecting certain parts of the methylation cycle. So what do we want to do? We think about our family history because that really gives us a good clue. We always put our B12 in place and our cofactors in place. We think about other things that might be going on that might affect our ability to use our folate. So for example, if it's sulfur or brain fog or antioxidants, and use homocysteine as a bit of a guide, because if it's too high, you know there's probably not enough B6 folate, B12, or probably trimethylglycine. Or there might be a zinc deficiency because that BHMT enzyme really takes that homocysteine and helps recycle it through what we call that shortcut. But if it's low, well, what's going on? There's probably oxidative stress. Maybe they're vegan and vegetarian and they're simply not getting enough methionine from their protein to make SAMe to then regenerate to homocysteine. There might be a block in what we call the MAT gene, which takes methionine and converts it to SAM. So there's a lot of issues that we could have, but probably the most important is you're either taking too much B6 or there's oxidative stress. Thyroid function, definitely consider that because that's a really big issue, particularly with B2. And gut, and you will have, over the last month, if you've been listening to my Facebook groups every Wednesday, then you'll know that gut has a huge part to play on the methylation cycle. Estrogen metabolism, really important with anyone that's got MTHFR because you're going to be affecting your breakdown of estrogen, and that will definitely affect your methyls, and it will increase your dopamine potentially, and that can definitely affect your ability to use folate. Okay, so ideally we want you to work with a healthcare practitioner because, as you can see, it does take some work to understand what you need to do. I've tried to simplify it tonight to make it as simple as possible for you, and on the whole this works really well as long as you've got something in place to get rid of the methyl if it's a problem for you. So we have got, you will have got an email. So we've got a special offer. I think, Emma, if you're still online, then it'd be great if we can pop that into the chat box so you can see it. Oh, she's put it into your email. So she's actually put a message there. You can see in the chat box. Emma said, "Hi everyone, please make sure you check your email for our special offer." So the special offer is basically if you order your products tonight within an hour of this webinar finishing, you get 20% off. If not, you've got 24 hours to take advantage of the offer and you'll get 10% off. So we thought we would put that in place for all of you for tonight because I know that you're all interested. So let's now take some questions, and I'm sure there's a lot. I'm just trying to get the question box out. Okay, so so Lee is saying that they haven't tried any medication yet because they are bipolar, so scared to take anything, and I completely understand that. And you do have to be very careful. And I think by doing the B12 and the starter B firstly, you are not really going to affect your mood in any way negatively. It's very unlikely that you would have a reaction to those two. Where you have to be very careful is understanding exactly where, if and when you would put in methylfolate. And ideally, with any neurological disease, you really, really should get a practitioner to help you. But certainly, starting with your B12 and your starter B would actually help you considerably. And Sam has said she's had some of those side effects and currently unmedicated and undiagnosed. Okay, so Sam, does that mean that, okay, so when you say those, you have the methylfolate side effects even though you're not taking any supplements, is that what you mean? Just maybe you could tell me that. Are there different types of B12? Yes, Julie, we answered that, and I think that came in through that part of the presentation. What type of B12 can I take if I have dental fillings? You can take any, Melissa. There's no right or wrong. If you have dental fillings, you can take any of those B12s. If I already have blood tests that says I am homozygous A1298C, do I have to pay for another test through you as it's genetic and I got the first test free? No, because your genes will not, your genes won't change. You will be homozygous A1298C for the rest of your life. Nothing will change that. So no, once you have a test, you don't do anything. You just keep that result and then you will also know. Kate is saying, my son is diagnosed with autism spectrum disorder. I'm MTHFR 677 and my daughter is M677 and A1298C. So Katie, are you homozygous or heterozygous? So then there's a good chance that your son will definitely be MTHFR, one or the other. More than likely, if your daughter's something to go on, he'll either have 677T or A1298C or both. Katie's saying, I've been feeling fatigue, etc. for years, even before my son. How would I go about helping him? Okay, so you can do pretty well the same for your children, but do it at half the dose. So, for example, you would use a quarter, and instead of moving it up quickly, I would put him on a quarter maybe for a couple of weeks, but only go to a half and see how he goes. And I think children with autism spectrum disorder probably would benefit from that dose of the starter B, but I would also do the same thing. Break the capsule open and give them a quarter of the capsule and do that for a week. And then just put it in a little bit of juice or something, or mix it into his breakfast cereal, and just give him slowly little bits and just see at what dose he gets better. But then I definitely would be very cautious about the methylfolate, and I certainly wouldn't go above, say, a quarter for them, so 100 micrograms. You don't say how old your son is, but I definitely think 100 micrograms is perfectly fine for a child, and even 200. Samantha was saying that she was told to take a B complex number 12 by Thorne. So I like the step-by-step process, because I really think you are getting good doses of therapeutic nutrients in place first. I mean, if you're fine on the number 12, it's just got more B12 in there, and that's okay. There's nothing wrong with that. And if that suits you and you think that's fine for you, then absolutely stick to it. Thank you for making them chewable. Yes, and you know, Leanne, kids really love these. They love the taste, so it makes it easy. Okay, so Katie, good question. Your starter B has B6 in it, but my bloods say I have high B6, so what can I do? Okay, the dose of B6 in the starter B is actually very low. But if your bloods are saying high and you are not taking B6, then that's a problem because you are not absorbing it. And the reason that you're not absorbing it is because you don't have enough lysine, because you need lysine to help the absorption of B6. So what I suggest you do is you take your lysine first and then introduce the starter B. Do you know if low dose naltrexone would interfere with methylation or maybe could be helpful? Look, I think if you did it for a short period of time, as in months, not years, I think it can be helpful for some people, but you wouldn't want to do it, I don't think, for a long time. So I just think definitely low dose naltrexone helps a lot of people, and I would just say, yes, try it for a short period of time. For a long term, though, we wouldn't want to be doing that because it will deplete certain nutrients. And Leanne is saying, thank you for a great job at simplifying it. Thank you. Rochelle's saying, I can't tolerate SAMe. I have a comp SNP homozygous. Why would that be? As comp needs SAM as a cofactor. So when you say you can't tolerate SAM, I would want to know, A, what dose you were taking, because I think people start off with way higher too high a dose. The other thing I would be saying is, are you taking your cofactors? So are you taking B12 and are you taking something, you know, like, are you taking starter B? Because like methyls, SAM still needs its cofactors and you need the cycle to be moving. On the whole, you're right. People with comp tend to do okay with SAM, but I've got some people who are homozygous comped that actually do really, really well on a little bit of methylfolate. And when I say a little bit, maybe 200 micrograms, so half a capsule, or say one total B every second day. But you definitely need your cofactors in place with SAMe the same way that you do with methyls. So that might be your problem, Rochelle. Oh, I think I just deleted one. Okay, I think that was from you, Leanne. I'm sorry, I just deleted one of your questions, so maybe you can pop that back up. Samantha saying, I'm a vegetarian, so I would like to know the best way to supplement this. Exactly the same way, Samantha, but I think what you need to do is probably take 2 methylcobalamins, not 1. So you probably need the added benefit of 400 micrograms, not 200 micrograms. So you've just got to take B12 every day and take your starter Bs, and you do it exactly the same way. You're probably getting enough methylfolate if you're a good vegetarian and having a lot of leafy greens. So I would definitely just check how you're going with that, but definitely. Could you use a combination of the Bs from Deb? Yes, absolutely. And I often do that, you know, a combination of adenosine and methyl, or methyl and hydroxy. Absolutely, you can play around with those to see which suits you best, definitely. Narelle, would you recommend doing just MTHFR gene testing or go straight for 23andMe? Okay, and she's had cancer. All right. So you've got some quite significant health issues there, Narelle, and so I think I probably would like to see a 23andMe. Normally I would say don't worry too much about it, but I really would like to see your COMT gene, particularly with cancer. You need to you really need to make sure, and I would want to see some of the other key genes in the methylation cycle. So yes, I really think you probably need to do your 23andMe. I think you'll get a lot more information, and that will help you long term. Melissa, as I am pregnant, so obviously, what type of B12 can I take if I have dental fillings? Is that okay? You can take any type of B12 if you are pregnant. I think probably methylcobalamin I would prefer, not for any general preference other than it's going to be probably better all round. Is it an idea to start B12 and Starter B before I start my first appointment with you? Yeah, I actually think it is, because in most instances, that's exactly what I would start people on. I always think you've got to get the cofactors in place, and I always think you've got to get B12 in place. Do I do private consultations? Yes, I do. And most of our practitioners, or all our practitioners, do Skype appointments. The problem is I've got a very long wait list, and I think we're currently up to September, but I have 5 amazing practitioners. So if you need to see someone now, get in touch with our office, and you can just email inquiries@mthfrsupport.com.au, and I'm absolutely sure that we can get you in sooner rather than later. But if you want to see me, you'll have to wait till September at this point. Sorry about that. Nicolene's saying she's tried Folinic, never tried 5-methyl, trying for children. So doctor said I need to take folic acid, which I've been taking for over 2 years now, just assuming they are different. No, you should not continue with the folic acid, particularly if you are trying to fall pregnant and you have the MTHFR gene. I absolutely categorically feel really strongly about that, and you need a prenatal with methylfolate in it. So Nicolene, contact our office tomorrow morning on 02 9908 1888 and ask them to send you a methylfolate prenatal. And it has a combination of folinic and methyl, and you definitely need that, and just avoid the folic. Leanne, is there if there are SNPs in TCN2 and 3 on 23andMe, would injections be a must, or would the chewables be okay? Okay, good question. So I think generally I would start with the chewables and see if the patient gets improvement. If not, I then go for B12, because I think some people need the injections because they absolutely need to saturate their enzymes with B12. So almost completely overdo it, and that's what I had to do with my MS patient. So definitely try the chewables first. If you don't get the full resolution that you need, go with the injections. Samantha is saying agitation, anxiety, suicidal, headaches, fatigue. I suffer these daily. We'll be testing for MTHFR in the next few weeks. Just wondering if these issues are related. Yes. So Samantha, are you taking any methyls? If the answer is no, then you need some niacin straight away, because what that sounds like to me is that you are creating methyls, but you're not using them. And so because you're not using them, you're getting side effects similar to what you would get from taking methylfolate. So you need to get that niacin into you now to basically mop up those methyls until you can use them. So get your B12, and once you've done that, get your B12 in place, and get your make sure that you get your cofactors in place, and do not start methyls. You need to use them first. And I really, with all of that going on, I would strongly recommend that you see a practitioner. I wouldn't like you to try and do that on your own. Julie, is 23andMe the best place to get tested? If you just want to test for the MTHFR gene, then no, just jump onto our website, get one of the kits, do it at home, and they will tell you whether you have the MTHFR gene. If you have really serious side effects, so serious health conditions, then absolutely, you know, you might want to do the 23andMe. But other than that, you know, normally most practitioners can work with you just with the MTHFR, which is what I'm talking to you about tonight. Leanne, how do you tell if you need folinic as well as 5-methyl? Yes, the SNPs that tell you whether or not you need folinic is actually the MTHFS and the SHMT. So that usually gives me an indication if you've got those SNPs homozygous. I tend to not give you folinic, and I will give you 5-methyl. And if you're homozygous 5-methyl, homozygous MTHFR, I would prefer to give you 5-methyl. So it just depends. It's a bit of a harder one to say, but normally most people will normally most people will actually I'd start them on methyl. I would actually prefer to start people on methyl because I see less people needing folinic and more people needing 5-methyl. So that would be my preference, but then a combination, particularly in pregnancy, is better. Nicolene, just to confirm, I also take methylcobalamin. Yeah, so methylcobalamin is fine, Nicolene. It's actually really good. And this is Katie talking about her son. He's super fussy. I'm not sure he'd take it and cannot communicate much. Well, you know what? You need to be really tricky, and if you have to, mash it up and put it in some stewed apple or something like that. But I usually find that most kids, doesn't matter how bad they are, will usually take it. I think they probably chew the B12. As far as the other, what I would do is just make some stewed apple, a little bit of apple and water, make it into like a paste and hide the supplement in there. And 9 times out of 10, they don't know. And Katie said he's 9. Well, yeah, just hide it in something, Katie. I think he'll be fine. All right, we're running out of time, but I'm going to try and get through these as much as I can. I've been taking Methylguard by Thorne for around 12 months, and my B12 is around 860. Should I continue with Methylguard? Right, so Seema, the most important thing is what is your homocysteine level? If you've been taking Methylguard for 12 months, the whole purpose of Methylguard is to reduce homocysteine levels, and you may have reduced it way too low, which means you are affecting your methylation cycle. So I would say check your homocysteine. If it's below 6, get off Methylguard and go on to your total B. Don't continue with Methylguard once your homocysteine is sitting between 7 and 8. Leanne, the best way to get rid of oxidative stress? Oh, well, that's the $50 million question. But really, you want to support glutathione regeneration. So you want to make sure that your zinc and your selenium and your N-acetylcysteine are at good levels. So a lot of people with oxidative stress have it because their cysteine levels are so low. And that is a B6-dependent enzyme. Their homocysteine could be low. So there's a lot of things that affect oxidative stress, but the 3 key nutrients that support it outside glutathione are zinc, selenium, and N-acetylcysteine. And you should never put glutathione in unless those 3 cofactors are in there first. Okay, is there a specific practitioner I should ask for given my history? Okay, I just have to go. I might contact you offline, Nicolene, to answer that question. And And perhaps if you could send an email to inquiries@mthfrsupport.com.au, just outline the key issues again, so I don't have to go through all these questions, and then definitely, definitely see if we can find someone that matches you from the clinic. Okay. Katie, my daughter has epilepsy as well as MTHFR 677T and A1298C, was advised to have folic acid. I've told her to stop. What can she take instead? So you're going to go through the same process, Katie. You know, you're going to support her B12, you're going to put the starter B in place, and then you are going to have a look and see if she tolerates any methylfolate and go really slowly. Epilepsy can well be a problem with B6. It can be a problem with a lot of different nutrients, but getting those cofactors in place are really, really important. Does histamine give an accurate indication of over or under methylating? Not really, and I do get histamine tested, but I always go on signs and symptoms, because you can often have people who have low histamine levels, but they are having hives and they've got asthma and they've got allergies, and there's no question that there is a problem with histamine levels. So I disregard the blood histamine, and I will always go on symptoms, and 9.5 times out of 10 that's right. How much methylfolate should I take? Also trying for a baby, had 1 miscarriage, 1 ectopic, I'm heterozygous, my husband has the same mutation and is taking Thorn B complex. Does he need to take extra folate or the 400 micrograms in the complex? With a heterozygous A1298C, that actually should be enough. And for you, somewhere between 400 and 800 would probably be ideal. But what could work really well is for you to also get the prenatal we've got in the clinic, which is 500 of folinic and 500 methyl, and so that actually might be quite good for you. How long to take lysine before starter B? Only a few days, you know, maybe 3 or 4 days, and then continue to take it while you're taking it. And yeah, the niacin, that sounds like you. Okay, so yeah, okay, so if you are getting side effects like what Samantha was saying, and you're not taking any methyls, then consider your methyls are not being utilized, and perhaps you don't need methylfolate. So you will stay on starter B and your B12 until you get the other stuff organized. You look at your zinc, you look at your B6, you look at your homocysteine, and you check all those. And some people never take methylfolate because they're creating it okay. Their problem was always that they couldn't use it. Oh, Katie's saying he doesn't eat fruit. All right, well then put it in a milkshake. I'm sure he'll drink a little chocolate milkshake or something. Use some raw cacao and make him a little chocolate milkshake, maybe with some coconut milk or something that he can tolerate, and chuck it in there. You just got to be clever, Katie, and it doesn't matter what what you can get it into, just give it to him. All right, I've kept you long enough, so sorry to keep you. Great questions, thank you so much. Don't forget our offer on tonight. Jump online, take advantage of that, and I'll look forward to seeing you either on our Facebook group next week at 3 o'clock on Wednesday, or again for next month's webinar. So take care, hope you all stay well, and I'll talk to you soon. Bye for now.